Dr. Yamini, thank you very much for agreeing to speak with me today. Tell me a bit more about yourself, please. How did you end up being a dentist?
It's my pleasure to be here. And I always wanted to be a doctor. But then when I wrote my CET and got my ranking, I was 11 marks behind my selection for to take an MBBS seat. That's when I thought I wanted tag of doctor. But then what is our alternative to MBBS? Then to my ranking, there was a dental seat available, and then I was very happy to take up the dental seat. The thing is, I always wanted to work for the patients. I've seen my cousins do a lot of patient work. They have been MBBS doctors, the dentist in the family. I've always been inspired seeing my cousins that I also need to be a doctor and then treat these patients. So that gives a lot of satisfaction. That's when I decided, if not MBBS, I should do dentistry. And then I was a lot fascinated by the work they used to do. So I've seen the kind of work they have done, and then the outcome, and then how the patient is so happy with the treatment outcome. So that's when I decided I should take up dentistry, and then here I am. So
So, when did you finish your dental training and where did you do it?
yeah, I'm a girl from Namma Bengaluru, the silicon capital of India.
Nice.
So I've done my education here in Bangalore, including my undergraduate program. The specialty training also is done here in a college called Bangalore Institute of Dental Sciences. So it's a postgraduate institute, one to start after Government Dental College also. So it's one of the premier institute in Bangalore because of the library facility or the patient inflow. So that's where I graduated, did my master's. So I'm practicing here. So living in Bangalore, I think it's a blessing.
Nice. So, you did your undergraduation here in Bangalore as well.
Yes.
Which
Yes.
college was that?
I did in Kaili Society's Institute of Dental Sciences. That's my alma mater. That's where I practice. It's an academic institute and an hospital. We do teach undergraduates and the postgraduate students. We have a PhD program also in the department. And then there is an attached hospital. We caters to all needs of dental problems, starting from the gum problem to dental decay to complex craniofacial reconstruction. So that's an academic institute plus an hospital. It's in Bangalore, and then we are doing really wonders.
Very nice. So, undergraduation you did in basic dentistry, I suppose. And then you have to choose specialization, isn't it?
Yes.
There must be many kind of specialties for you to choose from.
Yeah.
What did you choose?
So in dentistry, we have 9 specialties, and one of the branches is Prosthodontics, which I'm specialized in. So I always seeing my teachers, the mentors, the seniors. I was so inspired, to see the kind of treatment that prosthodontists do.
What is it? What is it?
yeah,
Well,
yeah.
for lay people, when you say
Yeah.
prosthodontist means what?
Yeah.
What do you do?
So I was always fascinated to do that kind of work. So that's when I did during internship. I thought I should be a prosthodontist. So it was my intention and my interest that I wanted to be a prosthodontist. So prosthodontist is a person where we specialize in replacing, restoring and reconstructing the missing teeth, the missing natural teeth. And by doing so, and we also reconstruct the missing facial parts, that is the defect of the craniofacial structures. We reconstruct and restore the missing eye, maybe a missing ear, missing nose. So we, apart from restoring the intraoral structures, we do rehabilitate the missing or the defective extraoral structures as well. So we prosthodontists do take a wonderful pride in treating conditions that can alter the course of one's life. So lot many patients with the craniofacial defects who visit us, maybe it can be an acquired defect or it can be a congenital defect. So we prosthodontists do treat all of these conditions. So the missing natural tooth, maybe it a single tooth or a multiple missing teeth, we replace them with an artificial crown or a bridge or a denture or an implant.
If you break it down,
Yeah.
like when you said missing some part of the facial anatomy, how do these patients present to you? With what complaint?
Yeah. This patients with the craniofacial defect, that's what we are discussing, they can present in 2 types. There can be an intraoral defect or an extraoral defect. The patient might present with the defects of the intraoral missing part anatomical structure or an extraoral missing anatomical structure. So the intraoral defects can be a defect of the maxilla, the upper jaw, or a defect of the mandible, that's the lower jaw, or there can be a missing tongue. Even we rehabilitate those kind of patients. So these patients present to us with the defect of the oral structures, and then the probable reasons could be tumor, it can be a trauma or a surgical excision of the tumor, or it can be iatrogenic reasons. So we do rehabilitate this kind of patients with see if, for example, if the patient has a defect in the maxilla, it can be a congenital reasons that is called as a cleft lip and palate, no? Or it's a combination of cleft in the lip and the palate, or just a cleft palate. So this is usually seen in younger children. So if it is not surgically corrected, or the patients are not fit to undergo surgical correction because of various reasons, so we do play a role in rehabilitating these kind of patients, where we give a patient with the prosthesis, so that no, that prevents a communication between the oral and the nasal cavities. Thereby, the patient can talk well. There is no nasal twang in his speech. The speech reproduction is better. He can take the food. There is no oral and the nasal communication. The nasal regurgitation is prevented. So that's where we fabricate a prosthesis there.
So these patients, do they come to you directly, or it's usually picked up in the community somewhere and you get referred?
These patients are referred by the oncosurgeons sometimes, or they themselves know that they'll have to visit a dentist post-surgical. They are referred by the surgeons that they'll have to visit a prosthodontist or a dentist for a rehabilitation. So the patients visit us in the regular OPDs, or they're usually referred.
What is the commonest thing that they come with?
They come with the complaint of telling that food just goes into their nose. So because there is a communication between the nose and the oral cavity, so they tell that they're not able to swallow food, difficulty in chewing, difficulty in swallowing, and
Speech also, I
speech,
suppose.
speech.
So it's more of a functional thing which is hindering them, and then they come to you and you find an anatomical problem there, isn't it? So how do you work these patients up? What all investigations do they go through?
So when they visit us, the first appointment, there is a direct interaction between the patient and the dentist. So we'll have to interact with them, understand their psychological. They would be really affected psychosocially. Not these patients not only suffer from function or the aesthetics, but they'll have the immense psychosocial issues. So we'll have to sit with them, talk to them, analyze what they're going through, how important is our rehabilitation that's going to make a difference in their personality. So that's when we step in, and then psychologically we counsel them. And then once they are okay with the kind of treatment that we are going to provide, once they are okay, then we are going to start with some kind of investigations, maybe a radiograph, just to know what kind of bone support we have, and the intraoral examination is done. So after complete evaluation, we go ahead with prosthetically fabricating a prosthesis for
So
this
you
kind
do
of patients.
CT scans, MRI scans?
Yeah, we do CT scans, MRIs. If at all, if the patient, there are two types of rehabilitations that can be done in these patients. If the patient doesn't have sufficient bone quality to go for a very definitive kind of rehabilitation with kind of dental implants. So we do conventional prostheses for the patients, wherein we can use an adhesives or some mechanical retention, wherein the prosthesis can be held in place. So the defect itself can hold the prosthesis. But however, if we have a sufficient quality of bone, the maxillary bone, the premaxilla maybe, the zygomatic bones, or the pterygoids even, if they are all intact, we can use and place the maxillofacial implants, and then this prosthesis can be anchored to those implants.
So they can come with a functional deformity, and then you evaluate that thing.
Yeah.
Do they come with specifically cosmetic problems?
Yeah, these kind of patients complain both of functional and aesthetic problems. So thereby, when we fabricate this kind of processes, we restore aesthetics and of course the function, and more importantly, we add value to their life. We reconstruct, we revive, and restore their lives with confidence. Their quality of life is going to be drastically improved.
What are the common pathologies that they would need this kind of an intervention?
Most commonly in dentistry, we see the ameloblastomas, the squamous cell carcinomas,
Tumors,
the
this is
tumors.
the
It's basically
cancer.
the cancer. The cancer is one of the most the affecting. According to ICMR, India stands first with the occurrence of cancer, occurrence and the prevalence of cancer in India. So the most common sites, apart from the lung and other regions, it's the mouth and the tongue. It's most commonly affected, and the prevalence, if you see the gender wise, the females are more commonly affected with the cancer than the males. That's what the recent ICMR guidelines, the report tells. So,
So they get diagnosed with cancer, and then they have. Do you do that cancer surgery as well, or you deal with only the rehabilitation part of it?
see, the dentist, that is the oral and maxillofacial surgeon, he does the surgical correction,
Clearances and things
the
like that.
surgical removal of the tumor, and the patient undergoes the radiation. Post all of this treatment, this kind of patients visit us, and then we play
So
a
you
role
take
here.
over from there.
Yeah, we take over from there.
Then you see what can be done to
Yeah.
better their aesthetics and function as well.
Yes.
Wonderful, wonderful. So, what kind of a setup do you have? Is it an end-to-end thing where you evaluate, treat, and manage their post-op as well, or do you deal with any specific set only and then you hand over the patient to somebody else?
Managing these patients is definitely a multidisciplinary approach where there is a general surgeon, general medicine specialist, general surgeon, oral surgeon. There is a speech pathologist. A prosthodontist is centered to all of this multidisciplinary team approach. Once the patient comes from the post-surgical treatment, undergoes a radiation, and he visits to us, so from then we take care to the post operative procedures, and from there on we might require an augmentation with the speech therapist. So this is just definitely a multidisciplinary team approach.
And it is a long-term process instead of a single-point treatment.
Yes.
Is that right?
Yes.
Okay. And so you do operate on, I've heard about this intraoral surgeries, like scarless surgeries. Can you talk to me a bit about that, please?
Yeah, the surgical part, we are just restoring. We are the architects of smile, and thereby restore the speech and the mastication. But however, there are scarless surgeries performed by the oral maxillofacial surgeons. So sometimes, if the scar band is left in the mouth, and then you're rehabilitating this kind of defects, the scar tissues help us in retaining this kind of a prosthesis, especially the scar tissues in the lateral wall or the medial wall. It acts as an undercut, and then it helps us to. It provides a prosthodontist an excellent field to gain an anchor to this kind of prosthesis.
What are these prostheses? What specific prostheses do you use to reconstruct?
Yeah, if at all, if I'm restoring a maxillary defect, it's called as an obturator prosthesis, wherein there is a plate that covers the defect, the nasal and the oral. When there is a communication, it covers up. It forms as an artificial palate.
Metal plate, is it?
It's an. It can be made with polymethyl methacrylate. It's usually a polymer-based processes. It can be a metal plate as well. It's an artificial. It acts as an artificial palate.
That's between the oral cavity and the nasal cavity.
Nasal cavity.
To do that thing.
Yes.
Then what about the jaw?
Jaw reconstructions. It can be done with autologous bone grafts. The tibia fibula grafts are being sectioned, and then they have been refashioned to fit to the jaw, and then the reconstruction is done. So over which the implants, dental implants, can be placed, and then it's beautifully can be rehabilitated.
And how do you counsel these patients that they can have a good quality of life functionally, aesthetically, and that these surgeries are possible and this kind of rehabilitation is available? How do you counsel these people?
Counseling is a very important aspect of treating or rehabilitating this kind of patients. We do have a special counseling team who counsel this kind of patients. They tell the plus advantages and disadvantages, or the problems they might have post treatment, or they completely free of all this kind of problems, and everything, emotional support, everything. We, along with the counseling team, we counsel this kind of patients until they are comfortable. We are not starting up with the treatment. Once they understand the treatment procedure, and once they're psychologically fit enough to undergo this kind of treatment, then we go ahead with
They have to
the
prepare
treatment.
themselves
Yes,
mentally, isn't it?
mentally, yes.
So when you say there can be problems during the process or after the process, what problems are they expecting?
For example, if the patient presents to us with a defect in the maxilla, for example, so the most challenging part, what we might face as a dentist or a prosthodontist, is the movable tissue bed. The plastic surgeons would have reconstructed with a skin flap. So it's usually keratinized. There might be a hair growth that's happening in the mouth. So these kind of flaps in the mouth or cause movable tissue bed that really hinders the retention of this prosthesis. That's a very challenging part that we commonly face. So that's why I mentioned it's a multidisciplinary approach, team approach. Always a prosthodontist, oral surgeon, and a plastic surgeon should be hand in hand and then work together. Communication is very, very important to avoid all this kind of challenges that we place when the patient visits to us. So this is one of the challenge that we see
That is,
most commonly.
that's one of the
So yeah,
complications or problem what they're looking at.
problem.
What functional problems or complications can they expect?
Yeah, this kind of patients, once we fabricate the processes, whatever the situation they come in, once we fabricate the processes, these patients might have problem with kind of retention, because there is no sufficient amount of support in the mouth, because the complete or the partial maxilla or the mandible would be surgically removed. So there won't be any support for our processes to be in place. So retention is one of the problem that we can have intraorally. The patients, there'll be no coordinated movement, there'll be deviations of the maxilla, the mandible especially. So the patient might not have a complete occlusion, occluding of the teeth. They might have problem with the chewing, the mastication. It's complete, there'll be collapsible nasal and the facial structures. However you reconstruct, that support won't be as it was like before. So these are some of the problems they might face. The looks, it might not be like how they were before. Though we try to rehabilitate more aesthetically as possible, the mastication, the chewing would be a problem because of the movable processes in place. But however, with the latest advances, there is a 3D scanning, the 3D printing. So this advancement in technology have taken over. It has revolutionized maxillofacial prosthodontics, and so here we can scan the defect well, and then there, with the designing with the CAD CAM, we are able to design the processes beautifully.
Custom built for the patient.
Yeah, it can be personalized kind of a treatment or a customized processes. It can be more faster, more accurate and precise process that can be fabricated involving the latest CAD CAM and 3D printing technology, wherein the patients are more comfortable with this kind of process than the process fabricated with the traditional methods. So we can make a difference with the advantage of the digitization or the technology.
Very nice. And as far as restoring function is concerned, you have speech, you have swallowing, and you have breathing.
Yes.
Three things which are happening in that complex. What order do you put as to the success rates for these three?
So first, I would say the speech production would be drastically improved with the prostheses, because the nasal twang is reduced. The air that comes out from the mouth, that's very important for the production of speech, that doesn't enter the nose when you stop the communication between the nasal and the oral cavities. So speech production is going to be an excellent improvement in this kind of patients post prosthetic treatment. The next would be, of course, the breathing would be really improved, and swallowing and mastication, of course, it's restored well.
How often do they need multiple surgeries or multiple involvements?
So once a surgery is done, So if it is not kind of a recurring tumor, post surgery, once we rehabilitate, the prosthesis will function well aesthetically and functionally for at least minimum of 4 years. 4 years once they'll have to come to us because there will be wear and tear of the material. So we'll have to check how the material is. All depends on the masticatory forces, the kind of diet the patient is taking. So his kind of life, how is going about this quality of life basically. But then once he visits to us, we completely evaluate how the teeth are in place, how the rest of the prosthesis is in place, and then there'll be kind of a resorption that's happening every year. So when he comes, we do take radiographs. We just see where is the underlying bone structure is. That's the basic support for our processes. So how well the process is maintained. So depending on that, we advise refabrication or remaking of the processes once in 4 or to 6 years.
Is it only the dental part of it that you look at, or are you doing rehabilitation for a bit more extensive thing like eyes and ears? You said,
Yeah.
how do you plan that?
So as I mentioned, we are very privileged and we do take pride in treating this kind of patients. Apart from treating the defects intraorally, we do rehabilitate and reconstruct the defects of the extraoral missing parts, like maybe a missing eye or a missing nose or a missing ear. We reconstruct with prosthetically. For example, if the patient comes with a missing eyeball, so we fabricate a process called as an ocular prosthesis. So only the eye shell is fabricated for the prosthesis. So if the patient has missing eyeball with associated structures, the eyebrows are missing, the associated bone is missing. So we do fabricate an orbital prosthesis where when we replace the eyeball, then the eyebrows, the eyelashes. All of which we fabricate with the aid of a eye shell and a silicone material. So we do orbital processes to reconstruct this missing eye part. So if it is a nasal structure that is missing, it can be a partial nose missing or a complete nose that's missing because of various reasons, because of trauma, again tumor, of any other reason. We reconstruct the missing nasal part with an artificial prosthesis. For example, it can be a conventional prosthesis that can be attached to a spectacle, just a simple a spectacle or a hairband, invisible kind of an hairband. So you can attach this prosthesis to the spectacle and then the patient can easily wear it. If at all the patient wants a very definitive kind of a prosthesis, again, implants are the excellent option where the implants are placed in the frontal bone or the roof of a maxilla, over which the process can be fabricated and can be anchored. So that's very wonderfully it works. So if the patient has a missing ear, it can be a partial ear missing or a complete ear that's missing. Again, we can we can fabricate a prosthesis with a silicone material that is a medical grade silicone, and then for a retentive purpose, again it can be an adhesive, or to be more definitive, again a maxillofacial implants can be placed in the bone that is available, and then the processes can be made retentive with this kind of definitive implants. So thereby we rehabilitate all of these craniofacial missing structures. And to add to it, we do play a role in cranioplasty. When the patient has the defect in the cranial vault, maybe again trauma or a tumor, the neurosurgeons remove the flap. So once they are removed and they're not able to place it back, we prosthodontists, we fabricate a preformed, pre-contoured cranial flap, or it's called as a cranial prosthesis or a cranial implant. So that can be screwed onto the side once it's fabricated, where it's pre-contoured.
You take a CT of the skull.
Yeah.
And
Yeah.
3D.
See, there are again two methods here. The conventional, if the patient is not affordable, or many a times the neurosurgeons advise repeated scans for repeated tumors. And then, though the titanium is a ferromagnetic and supposed to be, a good material for the cranial flap, but however, because of this, they have this artifacts, so the surgeons cannot diagnose the immediate structures. It becomes very critical for diagnosis of those structures, the brain tissues, post radiation. So here we play a role where when we fabricate a polymethyl methacrylate cranial prosthesis for this kind of patients. So conventionally impression techniques or no, using these materials where we usually follow a conventional prosthetic procedure, we can fabricate an acrylic cranial prosthesis for this kind of patients. So here we don't ask for any DICOM software or DICOM scans, but however when we are fabricating a 3D printed titanium or an acrylic flap, this DICOM scan software is useful. We asked for the DICOM scan, and then we have collaborated with the imaging centers wherein and the 3D printing centers where the softwares are useful, the scans are useful in printing the cranial processes in titanium.